Um, so we'll just jump right in. So, Susan already introduced me, but here's some pictures of my various animals and my two little humans. I'm currently in Cleveland, Ohio, um, but I've lived kind of all over the place, and I've been with Zomedica since March of this year. And today we're going to talk about cortisol. And when we talk about cortisol testing, we're talking about Cushing's or Addison's, but today we're mostly going to be talking about Cushing's disease. So we're going to review that. We're going to talk about why testing is so hard, how to improve pre-test probability, which we'll talk about what that means, and a Cushing's test overview. So to start off in health, we have corticotropin-releasing hormone, which is synthesized in the hypothalamus before traveling to the pituitary, where it's going to stimulate the release of adrenocorticotropic hormone, ACTH. This system, it's poorly understood, but influenced by many forms of physical, chemical, and emotional stress, including those things that you're seeing on the left side of the screen there: pain, trauma, hypoxia, hypoglycemia, surgery, fever, nausea, emotional stress, so many different things. And the synthesis and release of cortisol naturally and sporadically fluctuates throughout the day in healthy pets and in pets with illness. Cortisol is exerting negative feedback by inhibiting the synthesis and release of both CRH and ACTH from the hypothalamus and pituitary, respectively. And ACTH also exerts negative feedback on its own production and release. So to talk a little bit more about the negative feedback loop, this is a process involved in homeostasis where the product of the process is going to regulate its own production. And an excellent example of this is your home heating system. You select your preferred ambient temperature, dial it into the system, and this is the set point. And then when the system senses there's not enough warmth, it turns on. Warm air is provided until the system senses the set point, and then it's going to shut off. And this process is repeated throughout the day to maintain balance. In body systems, this is, negative feedback loop or homeostasis. And in the case of the hypothalamic pituitary adrenal axis, the set point is the desired level of cortisol to maintain normal body processes. So when cortisol is in excess, the system is going to shut down. When a lack of cortisol is sensed, ACTH is going to start being produced by the pituitary and stimulate the adrenals to make more corticosteroids, such as cortisol. And Cushing's syndrome is the term that we use to describe a range of clinical syndromes caused by chronic glucocorticoid excess. So there's actually several different etiologies of excess cortisol in the blood. In iatrogenic Cushing's, we have exogenous glucocorticoids that are provided to the system, whereas in naturally occurring Cushing's syndrome, we have excess glucocorticoids that are endogenous or internally created. And recently, experts have introduced a new category called subdiagnostic Cushing's syndrome, which we're going to discuss later. And if this feels a little bit different from what you've learned, this comes from Project Alive, which is a joint venture by the European Society of Veterinary Endocrinology and the American Society for Comparative Endocrinology. And the idea is to create a common language for endocrine diseases in practice. So in iatrogenic Cushing's, glucocorticoids originating from outside the body are introduced into the syndrome, aka steroids are being given to the animal. And here we have our typical hypothalamic pituitary adrenal axis homeostasis diagram. When steroids are introduced, ACTH synthesis is suppressed. The body's going to sense that there's already more than enough cortisol, and natural production essentially stops. This, of course, being the reason we taper our steroids instead of stopping them abruptly. Sources and types of exogenous glucocorticoids are numerous, as shown here in this chart. All glucocorticoids are kind of compared to cortisol in potency, otherwise known as hydrocortisone. With hydrocortisone at a 1, prednisone and prednisolone are 4 times stronger. Methylprednisolone and triamcinolone are slightly stronger than that. And then betamethasone and dexamethasone are coming in at 30 times more potent than cortisol. In fact, most of the steroids we administer as therapy are far stronger than cortisol itself. Thus, steroids that are administered topically in the ear and eye medications, as well as medications with decreased systemic absorption, like inhaled fluticasone or oral budesonide, um, are so potent compared to the natural body cortisol that even tiny amounts in the bloodstream can result in a profound effect. So, iatrogenic Cushing's is very common in veterinary patients, and we induce it to some degree in nearly every time we start a dog on chronic steroids. Naturally occurring Cushing's, on the other hand, is going to result from excess production of cortisol by the body. So, about 80 to 85% of the time, this is because of an ACTH secreting pituitary tumor, with the other 10 to 15% of cases from a non ACTH dependent adrenal tumor. Very rarely, ACTH or cortisol might be secreted in excess from elsewhere in the body. For instance, there's a very rare syndrome seen in younger large breed dogs where cortisol is secreted from the glands in the stomach in response to meals. This is called meal induced Cushing's, but it's rare. So let's look at the same HPAA homeostasis diagram in the case of an animal with pituitary tumor. These tumors are usually small and benign, but they exert a major effect by producing ACTH through a mechanism outside the influence of normal feedback control. Consequently, both adrenal glands are stimulated by trophic factors to grow larger and to create and secrete more and more cortisol. Although the negative hormone feedback loop is still active, it's essentially overridden by the ACTH release from the pituitary tumor. Because most pituitary tumors arise from a clone of a relatively normal cell, animals with ACTH dependent pituitary tumors often maintain a degree of the same normal fluctuations in ACTH and thus cortisol synthesis as healthy pets. In about 1 in 5 animals, the pituitary tumor can grow large enough to be classified as a macroadenoma. This is once the height exceeds 1 centimeter. Only advanced imaging such as CT, MRI can evaluate the size of the tumor, though there are several clues for the possibility of a macroadenoma that we can see during workup. That would include, obviously classical signs of Cushing's, but also potentially neurologic symptoms like seizures, somnolence, behavior change, change in appetite. They can also develop diabetes insipidus in addition to Cushing's, which, as you can imagine, would make that PUPD worse. In cases of Cushing's syndrome caused by adrenal tumor, cortisol and other corticosteroids are secreted autonomously from cancerous adrenal cortical cells through a mechanism outside control of the feedback loop. So cortisol is going to be secreted by the tumor and inhibit ACTH secretion, and all normal adrenocortical cells will become small and shriveled. And when you start looking at these adrenal glands, it's not just the opposite adrenal that becomes small, but any remaining normal adrenal tissue in the affected gland as well. Ultrasonography, we can see important differences in the size and shape of the adrenals that can differ depending on the underlying etiology. So along the top, we have typical left and right adrenal glands. It's not uncommon to see only the caudal pole of the right adrenal gland since it's located so high on the right flank along with the kidney on that side. In cases of pituitary tumor, the increased ACTH will typically cause a bilateral and symmetrical enlargement of the adrenal glands, which eventually will start to lose their central waist, as you see there on the right side. Although some dogs with PDH may have normal adrenals on ultrasound. And dogs can develop multiple adrenal tumors, many of which are incidental. And so just finding an adrenal tumor doesn't confirm Cushing's syndrome. In cases such as the one along the bottom, far more important than the finding of the adrenal tumor itself is that the opposite right adrenal and even the normal part of the left adrenal are flat and shriveled. Our last category here, subdiagnostic Cushing's, is a new category that was created by the folks in Project Alive, and this describes pets that have the clinical syndrome consistent with excess corticosteroids, including compatible clinical signs, lab findings, exam findings, but they either don't have increased cortisol in their bloodstream or we simply can't confirm that they do. And so previously, we call this atypical Cushing's. A non-cortisol secreting adrenal tumor is going to produce alternate corticosteroids. Remember that cortisol is just one of the products of glucocorticoid metabolism. Depending on specific mutations in the cancerous adrenal cells, hormone production may be skewed to a different type of corticosteroid like estradiol or progesterone. But this is a bit controversial in using these full adrenal hormone panels. In this case, the diagnosis would require evaluating more of the hormones produced in the adrenals. Finally, subdiagnostic Cushing syndrome is a term to describe cases that we truly believe to have Cushing syndrome, but we just simply can't prove it with our current diagnostic test capabilities. So no diagnostic test is perfect, and tests of cortisol are a prime example. And before we get more into detail about the applications for cortisol measurement in Cushing's, I really wanted to cover exactly why endocrinologists now recognize there's a subclass of patient with clinical Cushing's who have multiple tests of cortisol come back negative. So in the next several slides, we'll talk about these factors more in detail, including individual patient variability, assay interference, interassay variability, and issues of overall test performance. As already mentioned, serum cortisol concentrations naturally fluctuate throughout the day in response to a wide variety of physical, inflammatory, neurogenic, and emotional stimuli that are poorly understood. Unfortunately, this has complicated determining even normal reference ranges because we know that cortisol levels vary within pets over the course of an hour, a day, a week, and then there's even more variability from just dog to dog. So here we have a table of the reference ranges reported for 4 different assays of cortisol, which are very similar but still slightly different across the board. So remember that reference ranges are established using normal healthy pets of a wide variety of ages, and it's not the exact same thing as a diagnostic cutoff. So for a typical representation of the way test results are reported, we have the reference range here, which is the range of normal values that have previously been determined from hopefully a large population of normal animals. In this case, we've borrowed the reference range from assay 4 on that previous slide. Normal animals should have a canine cortisol at 8 hours of less than 1. A diagnostic cutoff is a number guideline that has been determined hopefully by studying a large population of animals with the disease in question, in this case, Cushing's. If we introduce a diagnostic cutoff here, you can see that it's possible for a patient with a reference range normal value to be classified as abnormal in terms of whether they have the disease in question. So we're going to talk about these things more specifically moving forward, but it's important to introduce the concept because a lot of people get very confused when we talk about tests of cortisol. Remember, when it comes to interpreting the results of tests of cortisol relative to whether the patient has Cushing's, reference ranges actually mean very little. What we really care about are the diagnostic cutoffs. So assays for cortisol measurement are also influenced by collection and processing. So interference is going to occur with samples that are lipemic or hemolyzed, and samples have to be centrifugated to separate the serum for test performance within 1 hour or for cool storage. Although dogs do not technically have to be fasted prior to pulling blood for tests of cortisol, we don't want to run the risk of having lipemia alter our results. Therefore, we typically need these pets to be fasted. At the time of running or storing the serum, if it's hemolyzed or lipemic, then I don't recommend proceeding. Something you can do in practice is wait until you have the serum from the first sample, take a look at it, and before you actually administer the ACTH or dexamethasone to make sure it's not hemolyzed or lipemic. Also, we know that exogenous glucocorticoids can cross-react with these assays and result in falsely high cortisol levels. And the one exception to that is going to be dexamethasone. So that's the exception to the rule. It's not going to cross-react with the cortisol assay specifically. And for this reason, if the pet requires therapy with steroids prior to cortisol testing, you should use dexamethasone. So this comes up in cases of Addison's disease, but shouldn't come up as much in a Cushing workup. But if a pet has been treated with 1 to 2 doses or a day's worth of any other steroid, then a 72-hour washout period is recommended prior to testing. And chronic glucocorticoid exposure is loosely defined as greater than 48 to 72 hours of steroid treatment. Past this threshold, suppression of the HPAA axis is going to occur, meaning that the patient's producing less of their own natural cortisol. So this is true of all steroids, including dexamethasone. So the amount of time necessary for the suppression to resolve is also fairly loosely defined. We can't know for sure, although current recommendations are to taper and discontinue the steroid at least 2 to 3 weeks before measuring cortisol levels. Individual assay performance refers to accuracy, precision, and reliability of the assay itself. For instance, the performance of the SNAP cortisol test has been questioned because of a small study that was published in 2018. In this study, samples containing known concentrations of cortisol were evaluated by the assay multiple times daily over several days, and the variability was around 25 to 30%. And this bias was most severe in that low to mid-range cortisol level. Although the correlation with 2 different reference labs was good, clinical agreement occurred only in 75% of the cases. That means that the results of the SNAP cortisol would alter treatment decisions 1 of 4 times. So the conclusions of this study were that borderline SNAP cortisol results should be confirmed with reference lab methods. So now we're going to talk about pre-test probability, and overall test performance characteristics such as what we just discussed are important in veterinary medicine because the likelihood that a patient has the disease being tested impacts the trustworthiness of our diagnostic test results. In other words, as it becomes more likely that the patient we're testing has the disease in question, the ability of the test to appropriately make the diagnosis increases, and that's called pretest probability. So what I really want you to take from this lecture is that when the pretest probability is low, meaning the likelihood this specific pet has Cushing's is low, our diagnostic tests of cortisol may perform no better than a flip of a coin. And we'll get into this more as we move along. So as clinicians, one of the most important things we can do to help ourselves working through cases of Cushing's syndrome, suspected Cushing's, is to make sure we're testing patients with a high likelihood of disease. And this could be a lecture of its own, but just a couple important guidelines to kind of help you identify what Cushing's suspects should we submit for further testing. And so first, this is a syndrome, this is a geriatric disease. So the median onset is 10 years old. It's nearly unheard of in patients that are less than 4 to 5 years old. And it's also a disease typically of small dogs, less than 20 kgs, and quite rare in large breeds, although large breeds who are diagnosed with Cushing's are more likely to have adrenal tumors than pituitary tumors. And the most common clinical signs are PUPD, polyphagia, and skin issues like alopecia, comedones, thinning of the skin. Derm signs can sometimes be the only symptom present, but PUPD is super common. The most common lab changes include thrombocytosis on a CBC, and there was a recent study showing that less than 480,000 platelets can actually rule out Cushing's with 99% certainty. And then we can see elevated ALP, GGT, cholesterol, and triglycerides. Those are the most common elevations on our lab work. ALP elevation without GGT is possible, but less common. And dogs with Cushing's rarely have a USG that's less than 1020, or I'm sorry, greater than 1020. Once we have established clinical suspicion for Cushing's, the low-dose dexamethasone suppression test is our diagnostic test of choice. and that's a really long name, but also I find the acronym equally as hard to say, so I usually just call it the low-dose DEX. This is the test of choice because it's really easy to make a false diagnosis of Cushing's. And with this, we're going to get the fewest false negatives, but the specificity or the ability of the low-dose DEX to correctly rule the disease in is still only moderate at 70%, which means that if the test is positive, there is still a 30% chance that we could be wrong. And at the end of the day, when it comes to tests for Cushing's, these really aren't yes or no tests. An abnormal low-dose DEX adds extra agreement to the statement, I'm seeing evidence of Cushing's syndrome. So evidence that should already be clear from our history, signalment, clinical signs, and lab work. So in performing this test, we're going to grab a baseline sample. A lot of people ask, is it necessary to perform the baseline cortisol? And absolutely yes, in this low-dose DEX test for evaluating the results. And we'll get to why that is in a little bit. So after collecting your baseline, you're going to administer 0.01 mg per kg dexamethasone IV, and you can dilute this out if needed. Samples for cortisol measurement are then obtained both 4 hours and 8 hours after that administration of dexamethasone. And remember that they should be hopefully non-lipemic, non-hemolytic, and spun and run within an hour of collection. And the first step in interpreting our low-dose DEX suppression test is to evaluate the 8-hour sample. So this is kind of our yes/no for our question, do we have evidence for possible Cushing's syndrome? And if it's high, then and the answer is yes, then we look at the 4-hour test to see if we can determine, is this ACTH-dependent disease caused by a pituitary tumor, or can we not tell? So looking at this another way, the low-dose DEX suppression test is going to aim to evaluate the ability of that HPA axis to respond to negative feedback by exogenous glucocorticoids. So first, we're going to go ahead and give the dexamethasone, which is a corticosteroid, in order to introduce negative feedback here at the pituitary. And in a normal dog, we are expecting to decrease ACTH secretion and release, and thus to decrease the natural steroid that's being produced. And remember that dexamethasone stimulates the system, but is not measured by our assays. So we know for certain that any cortisol we measure is actually coming from the dog. Graphically speaking, we have our baseline cortisol measurement here at time 0, and then we would look at the 8-hour time point first for the yes or no, does this look like Cushing's? And then the 4-hour time point next. Importantly, individual laboratory diagnostic cutoff points can vary. So generally, a cutoff of less than 1.4 micrograms per deciliter is used. However, some labs are going to use a cutoff of less than 0.7, which is an even more sensitive cutoff, which is intended to further decrease the chance of false negatives. It does this, though, at the expense of specificity, meaning you're going to have more false positives. So let's look at the same thing, but in the case of pituitary-dependent Cushing's. In this case, we have a pituitary that contains an autonomously secreting tumor producing ACTH. Thus, when we add our dexamethasone to the system and measure for a response, meaning we look at our adrenal glands and say, did the corticosteroid production decrease? We will find the answer is no, it did not, or not to the degree that we would have expected it to. And similarly, when we perform this test in an adrenal tumor case and we measure the adrenal production of steroid decreases, we find, again, the answer is no. We're still seeing excess cortisol production. So looking at this graphically, there are 3 typical patterns, and the first one is a complete lack of suppression. In this case, we're going to measure our baseline at time 0, and then we've collected our 4 and 8-hour samples. We receive our results back, and then we start by looking at the 8-hour test first, and we say, is there evidence of Cushing's, yes or no? And in this case, the answer is yes, because it's above our cutoff. Then we drop back and we look at our 4-hour test and evaluate whether we can confirm, is this ACTH-dependent pituitary Cushing's, or do we not know? In this case, there's a total lack of suppression across the timeline, so both the 8 hours and the 4 hours, and that's very consistent with Cushing's, but you can see this in both pituitary Cushing's and adrenal tumor, so we can't determine in this graph which one it is. The next pattern is called a partial suppression. These results, we have our baseline, and then we go ahead and we jump forward to the 8-hour, and we see there's no suppression at 8 hours. So our answer to yes, no Cushing's is yes, this patient has Cushing's, or we suspect Cushing's. Now, in this case, we look at our 4-hour results, and we see the 4-hour test is not suppressed below the diagnostic cutoff, but there was some sort of response. So we gave the dexamethasone, and the cortisol decreased a little bit. So we call this partial suppression, though temporary suppression is another good term for it. This is where you have to kind of do a little bit of math. You have to compare the 4-hour result of 2 milligrams per deciliter to the baseline, which is 4.5 milligrams per deciliter. And if the decrease is at least 50% of the baseline, which would have been 2.25, so here we're a little bit lower than that at 2, we can say that this is consistent with a pituitary tumor, an ACTH-dependent disease. So this is a different kind of result. We have our baseline, and then we jump to the 8-hour, and it says, yes, this patient has, signs consistent with Cushing's. So then we look at our 4-hour, and there was suppression at 4 hours, which was then lost. So this is called the escape pattern. These patterns indicate that the Cushing's is being caused by ACTH-dependent disease, aka a pituitary tumor. So to summarize, we have lack of suppression at 8 hours, then partial or complete suppression at 4 hours confirms pituitary-dependent disease. Here are all 4 patterns on the same graph, so we can kind of look and see the differences in how the test might be able to tell us not just yes Cushing's, but yes Cushing's and yes ACTH-dependent disease. Importantly, we can't confirm adrenal-dependent disease with this test. If it doesn't determine it, then you're going to have to do something else to kind of figure that out. The one final pattern that we'll talk about that you may have seen, this is called the inverse pattern. In this case, assuming the pet has a high likelihood of Cushing's based on our workup, we have our baseline, we look at the 8-hour, and our answer to the yes, no Cushing's is no, because it's lower than that cutoff. But we're looking at the PET, and we decided to run this test, so the PET looks like it has Cushing's. So what do we do now? And when we look at the 4-hour, we actually didn't have suppression at that 4-hour, but we eventually got there. So this has been long held to be suggestive of possible Cushing's because chronic exposure to endogenous glucocorticoids can slow the metabolism of administered exogenous glucocorticoids, in this case, the dexamethasone used in the low-dose dex suppression test. So other confirmatory tests would be needed. And a study performed looked at results of the low-dose dex retrospectively from 133 dogs who have been tested for Cushing's. And the overall performance of the low-dose dex in this study was like previous reports, with a sensitivity of 97% and a specificity lower at 67%. However, sensitivity and specificity provide no information on how reliable a test is at diagnosing or eliminating a particular disease in any individual animal. Something that is better indicated by the predictive values. So our positive and negative predictive values better reflect the probability of positive or negative test results being accurate. And predictive values are determined by the prevalence of the disease in the population under evaluation, meaning that for most laboratory tests, this information is not available. In this study, however, the prevalence of Cushing's was known, and it was high at 50%, because these were dogs that had testing performed because Cushing's was strongly suspected. The lack of suppression pattern has a very high positive predictive value when performed in a population of dogs with high prevalence of Cushing's. Our confidence is highest that we can trust the test result when we see this lack of suppression pattern. This confidence decreases when the pattern is partial and becomes far lower when the pattern is an escape or inverse pattern. The next step in cases with an equivocal low-dose DEX suppression test result and a high suspicion of Cushing's is to perform an ACTH stim. So our ACTH stimulation test, while it does require less time to perform, has a much higher rate of false negatives and is going to perform particularly poorly in dogs with adrenal tumors. So when we are purposeful in that we only perform testing for patients with high clinical suspicion of disease, we would not feel comfortable trusting a negative test result. Thus, why would we do it? So the main indication for ACTH stim is to follow up for cases with high clinical suspicion despite normal low-dose DEX suppression test results, and as the primary test of choice in diabetic dogs, which is a scenario where there's chronically high endogenous corticosteroids in the body that can blunt the effectiveness of dexamethasone suppression and result in a false negative test result or an inverse pattern. And then finally, we do these most often for therapeutic monitoring as well. The ACTH stim test is going to start by collecting your baseline at, baseline times 0. 5 micrograms per kg of ACTH, synthetic ACTH, should be administered IV. And this is going to create the most reliable absorption and thus be most trustworthy. There is a gel compound meant to be given IM, but studies have shown that the gel may not be absorbed and that absorption can be delayed. So if using the gel, post samples should be collected at both 1 and 2 hours to make sure we gave the adrenals time to maximally stimulate. The cost of this synthetic ACTH solution can be mitigated by dividing it into little aliquots and freezing it. And I don't recommend using the gel. So the principle of the ACTH stim test is by administering ACTH into the system, we expect the adrenal glands to respond by producing more cortisol. In a normal pet, which this picture is clearly not a normal pet, but if it were, when we administer ACTH, we are specifically hoping to stimulate the adrenal glands to synthesize and release more corticosteroids. So looking at this graph, in the normal patient, we see that the typical response to ACTH administration would be to increase the amount of cortisol being produced. This is measured by rechecking the cortisol level in 1 hour. In a patient with Cushing's syndrome, however, the stimulation is typically excessive. So again, diagnostic cutoff points vary depending on the exact assay that you're using. However, typically stimulation above about 17 to 20 micrograms per deciliter is suggestive of Cushing's syndrome. On the other hand, if the pet has Cushing's syndrome, we expect 2 things. First, they have an excess cortisol in the system, and the baseline values are generally above normal reference range. And second, stimulation is also excessive. Again, diagnostic cutoff points vary depending on the exact assay you're using. However, typically above 17 to 20 is what we're looking for the post. Here we're looking at performing an ACTH stim test in a pet with a pituitary tumor. First, note that we already have excess corticosteroids in circulation because of the increased ACTH that's being secreted by the pituitary tumor. Thus, when we measure the cortisol at baseline, it's typically already going to be elevated. The response to ACTH is intact, and as a result, the adrenals are going to produce even more cortisol that we have to measure at the 1 hour mark. Now compare this to the situation with an adrenal tumor, which is far less predictable. Similarly, the pet is already making a lot of excess cortisol and probably already has excess glucocorticoids in the body. But what happens when we add ACTH to this system depends on the makeup of the adrenal tumor cells themselves. Going back to earlier when we discussed that cancer is a clone of an abnormal cell, we must realize that whether the pet's specific type of adrenocortical cancer is still producing normal ACTH receptors or is still able to perform normal cell signaling, we don't really know. So the more malignant the tumor, the more likely it is that the cancerous cells no longer closely resemble normal functioning adrenal cortical cells, which explains why the ACTH stim test performs particularly poorly in pets with adrenal tumor. If the tumor can't respond to ACTH, we will not see additional stimulation, and we have an increased risk of a false negative result and a misdiagnosis. So remember that the sensitivity of ACTH stim tests, meaning our ability to accurately rule it out, is actually below 60% in dogs with adrenal tumor. There are many different patterns on an ACTH stim test that can be consistent with Cushing's, from a baseline that starts high and stays high to one that starts normal and stims high. Looking at this graphically, you can see that the baseline cortisol can really be anything, which begs the question, why do we do it? And this retrospective review of ACTH stim results in 54 dogs with confirmed spontaneous Cushing's stated that baseline serum cortisol concentrations cannot be used to diagnose Cushing's. An interpretation of the ACTH stim test is based pretty much solely on that post-stim cortisol in most cases. So looking at this graphically, the post-stim cortisol outperformed other cortisol measurements, such as the change in cortisol from time 0 to 1, or the ratio of the pre and post cortisol. And the goal for these types of graphs is to get as close to this upper left corner as possible, which is represented by that navy blue line for post-stimulation control cortisol. So what we really want to show is another example of how different diagnostic cutoffs can impact overall test performance. When the cutoff was set lower here, the ability to rule the disease out is improved, but that's at the expense of the ability to rule the disease in. So the higher the cutoff, the more specific the test becomes, the more we can believe that the pet truly has Cushing's. The take-home point being, if we feel more comfortable in our diagnosis when post-stimulation cortisols are well above our diagnostic cutoff, that's when we feel most comfortable. Finally, if your results of your ACTH stim test are mimicking Addison's disease, meaning the cortisol is less than 2 at baseline and after ACTH administration, but the patient looks like it has Cushing's, that's actually most consistent with iatrogenic Cushing's. So if the dog sounds like a dog with Cushing's, looks like a dog with Cushing's, has lab work like a dog with Cushing's, how could it possibly be a dog with Addison's? The answer is it can't. So the next step is to if you see this result, is to look for sources of steroids in the dog's history, even if you didn't see anything obvious initially. So there's our cushingoid dog. So that's really all about our tests of cortisol specifically, but I do want to mention just a little bit about tests of differentiation. So this is differentiating between our pituitary dependent and our adrenal dependent disease. So your ACTH stims can't tell you which one it is. Your low-dose dex suppression tests may be able to tell you if it's pituitary dependent, but they may not. So another option that we have is endogenous ACTH, which is a blood test that can differentiate this ACTH dependent pituitary disease or the ACTH independent functional adrenal tumors. So if you have ACTH dependent disease, you're going to have that pituitary producing excess ACTH. So you will see that. If you can measure that, you will be able to see it. Versus in our ACTH independent animals with adrenal tumors, you're actually going to see decreased production of ACTH due to that feedback loop. So why is it important for Cushing's syndrome? When you have that increased cortisol, which you're going to see in both cases, but you have high ACTH, now you can say, okay, this is likely pituitary dependent hyperadrenocorticism. If you have high cortisol but low eACTH, now you're thinking more of adrenal tumor. And there's other ways to do this, but all have their pros and cons. For example, ultrasound kind of depends on the skill of the ultrasonographer. So this is just a good blood test that you can do. Originally, this blood test, sending this to the lab, you're going to have issues with the fact that ACTH degrades very quickly. And so there's a lot of instructions. You have to keep it frozen. It's difficult to handle. And you often don't know if you can trust your results because of that. We do have this assay available on TRUFORMA, which means you can do it in-house and kind of eliminates a lot of the problems with this assay. So in summary, we hope this has been a helpful review of our diagnostic tests of cortisol as they relate to diagnosis of Cushing's. But the most important take-home points should be, remember that nothing's perfect. And while some of this relates to natural sporadic variability in cortisol levels, much of this can be mitigated by making sure we're testing only the best samples, only the non-lipemic, non-hemolytic samples. Remember that normal reference ranges can mean very little in the world of Cushing's, and it's really diagnostic cutoffs that we care about, and that these are determined by either the lab itself, that they're determined in the lab itself by the goal of optimizing our test performance, and they're established by research and are very assay specific. So you can't compare one lab value to a different lab's value. We can decrease confounding test results and confusion by only testing dogs that we have a high clinical suspicion of Cushing's. And when we do test them, we recommend using our low dose expression test, except for in diabetics. And even all the testing in the world may occasionally fail us because nothing's perfect. And endocrinologists do recognize that there's a subclass of patients that have Cushing's without your abnormal test results. You can always retest these animals. There's times where they just haven't developed as severe disease yet, and you're going to get negative tests, and you test them later and they will be positive. It's nice that when you have your low dose dex, if you're not getting the results that you imagine, you can go do your ACTH stim. So there's options, but nothing's perfect.